So hi everyone, welcome back to my YouTube videos. So today we will be discussing about a new topic, which is tachyarrhythmias. So in this video you will be able to know what are tachyarrhythmias, what different kind of ECGs you'll encounter. So let's start with a very good case scenario. Imagine this guy is walking into the emergency department where you are currently working, and he looks quite anxious, right? And he's very sweaty, and he tells you, doctor, I am having lots of palpitations and I'm feeling a little dizzy. So you connect the monitor and you see a pulse rate which is 190. So now you go for the ECG and you see a very weird pattern. Now, based on the ECGs and based on how our patient is looking, whether our patient is stable or our patient is unstable, and how good or how bad is the ECG, we'll proceed with the treatment, right? So in this lecture, we'll be able to find out what kinds of ECGs can present in such patients and what treatments will be going on, right? So before we start with tachyarrhythmia, let me give you just an overview. A heart rate which is above 100 or 120 is labeled as tachycardia, and as you can see that this is the P wave, this is the QRS complex, and this is the T wave. This QRS complex, this represents our ventricular contraction, right? So this QRS complex is very important. This will help us determine whether the problem is with the ventricles or the problem is with the atrias or anything above the ventricles. See, if the problem is above the ventricles, we call it as a supraventricular tachycardia, or nowadays it is also called as the narrow QRS or the normal QRS, right? So a normal QRS is somewhere less than 3 small boxes of an ECG, that is around 120 milliseconds in an ECG. So if you have QRS complex which is in this range, this is labeled as narrow or normal. So this tells us that our ventricles are perfectly fine. There is something which is above the ventricles that is causing the problem. Now when you see the ECG and you see that there is some problem with the QRS and the QRS is wide, so now you have to label it as the ventricular tachycardia. Okay, so the number one step that you are going to see in an ECG is what is the heart rate. If it is more than 100, 120, you think about tachycardias. After that, you look over the QRS complexes. If it is narrow or normal, you think about supraventricular, and if it is wide, you think about the QRS complexes that is causing ventricular tachycardia. So let's just proceed a little further, and we have different kinds of ECGs which I have pasted pictures of, and let's just try to make a little sense about it. Just giving you a little bit of hint, the ECGs which are on this side have a wide QRS, right? You can see that the QRS is very wide. It's completely abnormal. So this is definitely ventricular tachycardia. And the ECGs on the left hand side, the QRS is normal. It's narrow, right? As you can very clearly see. So this is supraventricular tachycardia, or which is called as the narrow complex tachycardia. And another pattern that you can identify is, as you can see in the ECGs which are on the left of this, they have a regular pattern, right? So the difference between each RR interval is quite similar. But as you can see here, the RR interval is irregular. So again, further we divide it into whether the RR interval is regular or the RR interval is irregular. So we have summarized 3 steps. The number 1 step is that you have to check the heart rate. Number 2 is you have to check the QRS complex. And the number 3 thing is you have to check the RR interval. And based on these 3 criteria, you are going to identify the types of ECGs. Okay, so let's just go with the first ECG. As you can see, the QRS is fine, everything is perfect. So it is just a sinus tachy. And I already told you in my last video, how do I calculate the heart rate? It is 300 divided by the number of small boxes, which is around 2 or 3, let's say. So it's 150, which is again on the higher side. So this is sinus tachycardia. It can be due to many reasons, maybe hyperthyroidism, maybe due to some some salbutamol usage or norepinephrine usage or cocaine users. Anything can happen, or pheochromocytoma, right? So these are the few causes for sinus tachycardia. Let's proceed with another one. See, in this ECG, can you see a little difference from this ECG? Can you make out that the P wave is absent? So in this ECG, you can only see the QRS and then the T wave. QRS, T wave, QRS, T wave, QRS, T wave. So the P wave is absent. Anywhere where you find that the P wave is absent, it is called as the paroxysmal supraventricular tachycardia. This is very important. Whenever you spot that there is no P wave, it's just paroxysmal supraventricular tachycardia. Now let's take a look at another ECG. Can you see that there is something weird with this thing? This is the PR interval and the QRS. QRS is a little widened and the PR interval is a little shortened. And you can see a typical delta sign. This is a special case scenario in case of ECGs. So decreased PR interval, widened QRS, these all are, and delta wave, definitely delta wave, these all are characteristic of WPW syndrome, right? So this is very important, and later on we'll be discussing about the treatments of each ECGs. Let's just make this clear, and let's just identify the ECGs. Let's come to the other ECGs which have an irregular pattern, but they have a narrow QRS. So as you can see that there are some fibrillatory waves, right? So anywhere if you spot fibrillatory waves with variable RR interval, it is due to atrial fibrillation. Okay, no doubts on this. And an ECG here, as you can clearly see that it's not fibrillatory, but it's there is some issue with the P waves. QRS is normal, so this is atrial flutter. Okay, so this one is atrial flutter, this one is atrial fibrillation. What happens is that in the atrial flutter, the atrial rate goes up till 240, 320, and the ventricular rate is 150. Although both are in tachycardia, but the atria is beating at a lot of higher rate. Okay, so let's move on to the other side where you have wide QRS, right? And in this ECGs, on the ECG that is on the left, you can see a pattern that the RR interval is quite regular. So anything which is regular with wide QRS is simply called as the ventricular tachycardia. Okay, so the complete umbrella term is wide QRS, ventricular tachycardia, and this regular one. And where you see an irregular pattern, this is called as ventricular fibrillation. Okay, and this special ECG and very famous ECG, this is of Torsades de Pointes. See, this Torsades de Pointes have a very variable looking ECGs. See, and you can also notice a pattern of this, right? So it decreases in amplitude and suddenly then increases in amplitude. And this Torsades de Pointes has many causes. So the few causes that I list in front of you is due to some electrolyte imbalance, that the potassium goes low, magnesium goes low, calcium goes low. So everything that is regulating the ventricular myocytes, it's going on its lower side. Plus, there are some QT prolonging drugs which can be remembered by a famous mnemonic, which is A, B, C, D, E, and F. This is very important. Whenever you read a stem, you have to see that whether our patient is on some special drugs. So A is antiarrhythmics. Antiarrhythmics means like amiodarone, sotalol, okay, and antibiotics. These antibiotics can be fluoroquinolones. This is very important. There is any medicine questions on this as well. And the macrolides. In antipsychotics, okay, so it's from P, but just remember it from C, it's antipsychotic. And which antipsychotic? It is haloperidol. So any patient who is on haloperidol, right, so the psychiatrists, they do refer them to NMD medicine so that they can monitor their ECGs and avoid any side effects of such drugs. So a patient might not die from psychosis, but may die from the side effects of such antipsychotics. And the antidepressants, which is TCAs, tricyclic antidepressants, and citalopram. Okay, and E, that is Emetex, so ondansetron. This is the pill that we usually pop a lot, so just be aware of it. It can cause arrhythmia. And droperidol. And in antifungals, it is the fluconazole, right? So that is why this is not a famous drug. Even if you look at the vaginal candidiasis, they do prefer a pessary over fluconazole, because fluconazole comes with its own side effects. So why make a person suffer through all that? So this was basically about the types of ECG that you can identify and then proceed with the treatment. So going for the treatment, see, if ever you encounter a patient who is sweaty and he says he's having palpitation, right, you connect the monitor, you check the heart rate, it comes out to be 200, then you take the ECG. Now you have identified the ECG. But before you identify the ECG, you also need to identify your patient. See, in the diagnostic pathway, don't forget where is my patient. So First of all, take care of the patient. Anywhere, if you think that your patient is unstable means that the patient has loss of consciousness, has syncope, has altered mental status, has angina, has pulmonary edema, or has dyspnea. Or if you check the vitals, the patient's BP is less than 90/60, the MAP of the patient is less than 65. So all this are characteristic of a patient being unstable. So will you go through this pathway and put the patient on specific drugs, or will you treat the patient? Definitely. First and foremost comes a patient. So when you know that your patient is unstable, you quickly go and check the pulse of the patient, so just keep your hand over the carotids and feel for the pulse. If your pulse is not there, if the patient is almost gone, you have to quickly call for help and defibrillate the patient. Very important. Okay. Or if you see that the pulse is there but your patient is unstable, you go for a DC shock. Right? So these are very important. If your patient is pulseless and is unstable, go for defibrillator. If your patient is unstable but has a pulse, go for a DC shock. But there is a special case scenario. If your patient has pulse or does not have a pulse, but on ECG there is torsades de pointes, you have to go for defibrillation. You cannot think about DC shock, right? That is not going to help. Now after this, you have a patient who is stable. Stable means he's not having all these symptoms. What you do now is you have to proceed depending on the ECGs, right? So depending on the ECGs, we'll be looking at different kinds of treatment. So let's just take a look at the treatment. So number one, this is the sinus tachy, very good. And this one is the PSVT. This one is WPW syndrome. This one is atrial fibrillation. This is atrial flutter. This is ventricular tachycardia. This is ventricular fibrillation. And this is torsades de pointes. So now just let's take a look at how are we going to treat the patient. For PSVT, let's just take a look at the PSVT. What you do is you go for a vagal maneuver. Right? This is very important. And this vagal maneuver can be of different types. This is called as the Valsalva maneuver. What you do is you ask this is the Valsalva maneuver. You ask the patient to breathe into the syringe, and then you ask the patient to lift not the patient, but the doctor lifts the legs of the patient, and then you recline the patient. This is called as the Valsalva maneuver. You try first the vagal maneuver, or if it's a child, you dip the face of the child in cold water.
Begin with the patient in a semi-recumbent position and ask them to blow into a 10mm syringe for 15 seconds. The patient should attempt to sustain the Valsalva maneuver for the full 15 seconds, though some may not be able to. Next, immediately lay the patient supine and support their legs raised to a 45-degree angle. Hold this position for another 15 seconds. This promotes venous return and increases the vagal tone. Finally, return the patient to the semi-recumbent position to complete the maneuver. This maneuver can be taught to the patient and family members to be self-performed.
So now let's just assume that these vagal maneuvers or dipping the face of a child into ice cubes or ice water doesn't help. So what you do next is you give the drug adenosine, and this adenosine has to be given in the dosage of 6 mg. This is important. The dosage is important. And after 2 minutes, if you don't feel that there is improvement, then you again go for a higher dose, that is 12 mg, and then you again go for 18 mg. So basically it's said that you can try up to 3 doses of adenosine, and if still this is not improving, you can switch to some antiarrhythmics. And still, if it is not improving, you can go for DC cardioversion. Okay. So the important drug that you have to remember is about the adenosine. And another important drug, as we know that this adenosine is contraindicated in cases of asthma. So you have to remember that this is contraindicated, and for these you can go for verapamil. Okay, the calcium channel blockers. So this is important thing that you need to remember about the treatment of PSVT. So let's now proceed with the treatment for our ventricular tachycardia. So let's just spot the ECG for ventricular tachycardia, this one. In ventricular tachycardia, you have to first go for the rhythm control. How do you control the rhythm? You put the patient on some antiarrhythmics, which is the amiodarone. And after the amiodarone, after you have controlled the rhythm, you go for a rate controlling drug, which is called as the beta blocker. And if this does not help at all, the amiodarone and beta blockers have failed, you have to go for cardioversion, right? And if you encounter that this ventricular tachycardia is seen very often in the patient and this is not recovering, so if it is a recurrent, you can't just go for an acute treatment. You need to do something which is permanent. You can't put the patient on risk of facing ventricular tachycardia so often. So what you do is you put implantable cardioverter defibrillator. Also about some sustained VT and non-sustained VT. See, a sustained VT is something that stays up till more than 30 seconds. That you have to treat with amiodarone. That means you need an antiarrhythmic to treat this sustained VT. But if the VT is non-sustained, that means the ventricular tachycardia is staying for lesser than 30 seconds, then you only need a rate controlling agent, which is a beta blocker. Or if it does not improve with that, you can shift to amiodarone. The important drug that you have to remember in ventricular tachycardia is the amiodarone, and that is the antiarrhythmic, and the drug that you need to remember in PSVT is the adenosine. But the important part that you need to remember before that, we always go for vagal maneuvers, which I told you, the modified Valsalva maneuver, or dipping the face in an ice cold water, or there can be carotid massage as well. Right? So now let's proceed to the treatment of torsades de pointes. So as I have already told you in the previous slide, that torsades de pointes is a special clinical scenario where you have to go for a defibrillator. But before we go extensively into the treatment of the torsades, as we already discussed, that there are few causes for this. So the number one step is that you remove all the causes, that you remove if the patient is on certain drugs, and you correct the serum electrolytes of that patient, and you put the patient on IV magnesium sulfate. Okay, and after that you need to go for a temporary pacing, that is the or isoprenaline, right? But if the patient of torsades de pointes is unstable, then you have to undoubtedly go for defibrillator. Even if the pulse is present or absent, that does not matter in case of TDP. But if the patient is stable, you can go with the IV magnesium sulfate and then the temporary pacings. So this was about TDP. Now let's discuss about the atrial flutter. So we are done with TDP, we are done with ventricular tachycardia, we are done with PSVT, and in sinus tachycardia, we go for a beta blocker. And let's just discuss about the atrial flutters. In atrial flutters, as I already told you, that we need to go for a rate controlling drug first, right? So the rate controlling drug can be a beta blocker, can be a calcium channel blocker, can be a digoxin. You need to select a drug based on your patient's preference, like what are the comorbidities in the patient. So a beta blocker is always contraindicated if the patient has bradycardia, or if the patient is a known case of COPD, as it can worsen that, or if there is some acute heart failure. In such cases, you are going to go for a digoxin. So digoxin is a drug of choice when there is heart failure, acute heart failure, or there is COPD, because these are the contraindications and these are the indications for digoxin. In the other cases, you can go for a beta blocker or a calcium channel blocker. And let's just move on after the rate control. See, if the rate control is not happening, helping the patient, what you do is you go for a rhythm control with the help of the amiodarone. And if still it is not improving, you go for some radio frequency ablation or anticoagulation. That's just beyond our scope right now. For the atrial fibrillation, we'll have a very separate video on atrial fibrillation where we'll discuss about all the treatments, because atrial fibrillation in itself is a very extensive topic that needs more of discussion, right? And let's just proceed to our next topic. This is a PVC. See, there have been few questions about the PVC, so let's just discuss this here. This is a premature ventricular complex, as it is very clear from the name itself that this is some premature wave that arises in the ventricle, and this premature wave is a widened complex. See, you can clearly see that this complex is approximately even equal to or more than 3 small boxes. So it's kind of more than 120 millisecond, and you see a very large T wave. And after that complex, there is a pause. This is called as a compensatory pause. So the heart needs some kind of rest after that PVC. That's called as the compensatory pause, which is characteristic for the premature ventricular complex. So It can be of many types. It can be bigeminy or it can be trigeminy. So what happens is that if it's bigeminy, it means that after every QRS there will be some kind of premature complex, and then there will be a QRS, then this. So QRS, a premature complex, QRS, a premature complex. But in trigeminy, what happens is after two complexes there is a PVC. After two complexes there is a PVC. So this is roughly an idea about the types, which is not that important. Now the important part is how do we treat it. So whenever you see an ECG and you spot that this is a PVC, what do you do? What you clearly need to understand is that this PVC has a cause. You have to find out the cause. So you treat all the reasons that can cause tachycardia. That means the patient might be on some kind of drug, the patient might be taking cocaine, or very important scenario, the patient might be pregnant. So pregnancy can also lead to PVCs. And how do you manage it? See, if the patient is asymptomatic, and you know, heart and our body is so beautiful, it can manage things all by itself. You just need to eliminate the cause. So if the patient is not symptomatic, just reassure the patient, treat the cause, and do nothing about it, and just monitor the patient. If the patient is symptomatic, you clearly need to do something. You go for an echo, you find out the cause, and meanwhile the patient is undergoing the investigations for finding out the cause or the echo and all, you just put the patient on a beta blocker so that heart slows down and there is, a little rest to our heart. And this another important ECG is of see, what's interesting about this ECG is that QT is very prolonged. Normally the QT has to be less than 480 milliseconds, but this is very prolonged. So if the QT becomes more than 480 milliseconds and there is a broad based T, right? It's not tall, but it's a broad based T, and this is called as congenital QT syndrome, long QT syndrome. So what happens is that you find out all the causes and you find nothing. So there is no secondary cause to this long QT, because we have already seen that there are some drugs which can prolong the QT, which is by the mnemonic A, B, C, D, E, F. But in this case, there is no cause, there is no secondary cause. So there has to be no cause, but there is a family history. You ask the patient, does your mother or father has such kind of heart disease, and then you do their ECG, they might also have a long QT. So how can a patient present? A patient can present with syncope. Okay, so what are you going to do for this patient? See, if the patient is asymptomatic, he's completely happy, and you just do the ECG and you find out that this is happening in his body, and he becomes a little sad. Why does this happen to me? So you just ask him to calm down, reassure the patient, tell him that you need to do some lifestyle changes, like you have to avoid any kind of exercise that's very heavy, you have to avoid any loud noise, you have to definitely avoid any QT prolonging drugs which are A, B, C, D, E, which we have already seen. So you just tell the patient to avoid all this and put the patient on propranolol, which is a beta blocker, right? So even if the patient is asymptomatic, you have to put the patient on oral propranolol because you need to slow down the heart. But if the patient has syncope, that means the patient is symptomatic, you need to do an echo and you need to send the patient for urgent cardiac review. So that's all about the long QT syndrome. And plus the important thing is you have to screen all the family members, because this has a strong family history. So that becomes very important for the patient. Next important one, which is a recall question. This is a ventricular escape rhythm. Can you see the heart rate of this ECG is very low? Can you just calculate it? It'll come out to be very, very low. So 1, 2, 3, 4, maybe it's just 20, around 20 or 30, such low heart rate. So the heart rate is very low. Another thing is, after a very long pause, see, there is a pause, this is normal, and after a long pause, the QRS is a little weird. Don't you think the QRS is wide? So there is a wide QRS which occurs after a long period, right? So it looks like the ventricle is trying to escape, right? So it's not beating properly, it's just coming late, and whenever it's coming late, it's taking a lot of time. So it's like a lazy ventricle. And why does this happen? Why is our ventricle kind of lazy? He's lazy because his bosses are not pushing him. Who are the bosses for ventricles? It's the SA node and the AV node, right? They control our heart. So if we have any kind of sixth sinus syndrome, that means there is some failure of the SA node and the AV node. This can lead to ventricular escape rhythm. And how do you treat it? If the patient is stable, just treat the cause. If the patient is symptomatic, you just treat it similar to that of the bradycardia that we have already discussed. So let's just take a look at the treatment for WPW. Okay, so in WPW syndrome, see, if ever you see an ECG where you see a WPW, what was that the PR, there is a little prolongation, and then after that there is a delta sign, and then after that you have this, right? So this is a typical of WPW on ECG. And if the patient gets symptoms, then you call it as a WPW syndrome. And if the patient has no symptoms and you just have WPW on the ECG, you don't treat it, okay? You only treat it in some special conditions that we will be discussing a little later, the special conditions where we treat just the ECG and not the patient. So let's just take our patient who is symptomatic, who has a WPW on ECG, that is WPW syndrome. So now you have to understand whether the patient's QRS is wide or narrow. So if the QRS is narrow, you go for a treatment which is similar to PSVT. What was it? Just go for vagal maneuvers, then the patient put the patient on IV adenosine, still no improvement, put on beta blockers. And if the QRS is wide, you have to go for procainamide. And mind it, you can never give a patient with wide QRS IV adenosine or a beta blocker. It's similar to killing a patient. So just write down amiodarone and put a big cross over it. Write adenosine, put a big cross over it. Beta blockers, calcium channel blockers, digoxin. You never give. Just the procainamide in wide one, and the narrow is similar to that of the vagal maneuvers. And definitely the unstable patient has to be treated with a DC cardioversion, which we have already clarified how to treat an unstable patient with palpitations or tachyarrhythmias. And the special conditions which we'll be discussing now is if any patient is a truck driver, right? He's driving and he does not he is at a higher risk that he can suffer from a sudden cardiac arrest, or if a patient is a pilot, or if there are some high risk on electrophysiological studies. In these cases, you are going to treat. And how are you going to treat? You just ablate that pathway which is causing that. See, I'm not completely going into the pathophysiology of the WPW or every other ECG, because if we go very deep into everything, it will become very extensive, and you'll lose the proper clinical medicine part of it. So now, after completing our session on tachyarrhythmias, now you know if a patient walks into the ED, let's just go back to the same patient we had, this one. Yeah. So if this person is walking inside the ED and you encounter this patient, what you do is you check for the vitals. You accordingly manage those vitals, attach a cardiac monitor just to see the pattern of the ECG, and prepare a defibrillatory pads. See, if the patient is unstable, you may need to defibrillate the patient, and definitely get an ECG and consult a cardiologist and send the ECG and do the things that you need to. And also this was the main crux, how you need to manage such a patient. So every time you see a patient with palpitation, always get a 12 lead ECG of that patient, right? And if that ECG comes out to be normal, you have to still suspect something, because sometimes the ECG might be normal at some points of the day. You have to go for ambulatory monitoring, right, which is by a Holter or an event recorder. This was a question in recalls since so many years, that if you get a normal ECG for a patient but he's complaining of palpitations, are you going to just reassure him and send him home? No, you're going to do something about it, right? Go for ambulatory monitoring with Holter or event recorder, right? And if this ECG comes out to be abnormal, then you know the drill. It's perform echo, treat the ECGs, and do everything. And so this is everything about the topic of tachyarrhythmias, although we are left with our very important topic, which is the atrial fibrillation, which we will be discussing in the different video, and a good topic about the cardiac arrest algorithm that we have to follow. Right, so see you in the next video.